This is Oyere Onuma. I'm a cardiologist and director of the Global Cardiovascular Health Program at the Massachusetts General Hospital in Boston. I'm also one of the associate editors at JACC. I'm very delighted to be here today with Dr. Phil Joseph, who's a researcher at the Population Health Research Institute and also a cardiologist at McMaster University in Ontario, Canada. Welcome, Phil. Today, I'm really excited, Phil, to discuss your recently accepted manuscript in JACC on the trends in the use of secondary prevention medications for cardiovascular disease. This study that you presented was a follow-on from the PURE study, and I was absolutely fortunate enough to shepherd this paper through the editorial review process at JACC. And I think that this paper really carries such an important message. So, Phil, I guess, my first opening question for you is maybe you can tell us a little bit more about the story of this paper. What motivated this analysis and kind of, led you to put together this manuscript?
Well, thanks so much, Oyere, and thank you also to JACC for the interest in this paper. So the justification for this paper was based on the need to understand what's been happening with the use of cardiovascular disease medications over time in the global setting and also in different health resource settings in countries at different levels of economic development. So this was also informed by two recent global targets that have been presented by the WHO and also the UN Sustainable Development Goals to increase the use of these medications over time or increase use of medications in patients with cardiovascular disease or cardiovascular risk. So we wanted to see in a contemporary cohort what type of changes are actually happening in the use of proven therapies in patients with cardiovascular disease.
Phil, I think you really hit on some very important points. Certainly this is a topic since, the publication of the original PURE paper and manuscript that has been at the forefront of some of these important global targets and important global movements, if you will. And certainly it is important to try to take a sense of what progress, if any, has been made towards these targets, given that there's such an important focus at this time. So I'm going to ask you perhaps to describe a little bit more of exactly how you went about this analysis and some of the key points or findings that you made in this paper.
Sure. Yes, and as you mentioned, this is an extension of the of an original PURE analysis that looked at use of cardiovascular disease medications at baseline, and it showed that generally their use was low, and less than probably half of people globally were taking any of these medications, with the lowest use in low-income countries. So we then looked at this in a repeat cross-sectional analysis of our cohort to evaluate over the course of a median follow-up of 12 years what has been happening in the use of these medications, both in patients with cardiovascular disease at baseline and then including patients that develop cardiovascular disease at each follow-up cycle. So overall, there were 5 visits over this 12-year period. And, during this time, we were basically characterizing the proportion of individuals on individual medications or also medication classes, and the main classes being antiplatelet agents, beta blockers, RAS inhibitors, statins, and also blood pressure lowering drugs, any blood pressure lowering drug in patients with stroke. So we were able to characterize the proportion of patients, on no therapy, on at least one therapy, on at least 2 classes of therapies, and 3 or more classes to try and understand, how the uptake is of these medications in our cohort.
I think, certainly this ability to do a more longitudinal analysis, and particularly, in a community cohort like you have with the PURE study is, really a key strength of the study. Phil, if you can just remind us what countries where was this analysis done in, and, was there any particular reasoning around the selection of countries that were included as part of this cohort?
Yeah, no, thanks, Rory. So the original, so PURE is an ongoing study and has actually undergone many different phases of enrollment of countries. So this included the original 17 countries in the PURE cohort. So there were 3 high-income countries, which were Canada, Sweden, and UAE. There were 7 upper middle income countries, which were Argentina, Brazil, Chile, Malaysia, Poland, South Africa, and Turkey. There were 3 lower middle income countries, which were China, Colombia, and Iran. And there were 4 low-income countries, which were Bangladesh, India, Pakistan, and Zimbabwe. And this was based on their WHO classification, World Bank classification at the time of their enrollment of the study. So this was selected, these countries were selected for several reasons, but one of the key reasons was we wanted to have representation from different parts of the world. And also representation from countries at different levels of economic development. So as you can see, this cohort actually includes countries from different regions of the world, and also very diverse in terms of their economic development, which was really the goal of the PURE study, to capture this type of data from places where there really isn't much data available.
Yeah. And I think, again, it's such it's such a well thought out study design, because what it allows us to do is to extend these results, quite widely in terms of external validity and the different sorts of contexts, be it, high or low income, or urban or rural contexts, that we are able to extend some of these interesting results that you found. So Phil, I'm going to ask you, what was the most surprising finding in this analysis to you?
Yeah, I think the most surprising finding was how little there has been in terms of improvement in the use of these medications over the period of time that we studied. So as I said, this was a median period of 12 years, and the median first visit was in 2007. And the median last visit that we collected data on was in 2019. And this actually crosses the adoption of recommendations by the WHO and also by the UN Sustainable Development Goals. And across this period of time, we really saw overall there was a decrease in the use of at least one class of these medications. In high-income countries had the highest use, as was consistent with other data, but the use of these medications actually were decreased over time. In upper middle-income countries, there was a small increase over time, which was about 6%, but that's a 6% increase in about 12 years. In low middle-income countries, there was a decline. In low middle-income countries, there was a decline. And in low-income countries, there was actually an increase up until the last visit, which partially overlapped, the COVID pandemic. And then in the last visit, we saw a decrease. But overall, the use of even one class of these medications was not improving over time. And in the overall cohort, less than half of people were still on, were not on, over half the patients were not on any medications, even at the final follow-up visit.
Yeah. No, Phil, I think I share that sort of surprise, if you will, an unpleasant surprise, really, at the abysmal conclusion around the use of these medications. And to be clear, we're talking about aspirin, low-cost medications like aspirin, generic statins, beta blockers, other kind of low-cost antihypertensives. So these are not, by any means, very expensive or new medications. We're really talking about, the most basic of medications and looking at these, really significant gaps. Something that stood out to me, for instance, was that in low-income countries, the numbers of people who've had prior cardiovascular disease, we're talking about the highest risk population on 3 basic medications, was 6% at the end of the study, 6%. And of course, the numbers you saw in low-income countries was a little bit inflated by the relatively higher numbers of treatment coming from India, where there's a little bit more availability of generic medications. So I think that, that's a really important message that you've highlighted, because it is with data like this that, policymakers, people at WHO, governments, researchers can start to think about ways in which we can begin to address these gaps. So I'm going to switch gear from talking about, all of the findings, really, again, negative, not negative, but, challenging and findings of this study, to ask you a little bit of, what are some of the reasons, in your opinion, what are some of the reasons for this lag in the use of secondary prevention medications?
Oh, thank you, Ray. As far as the reasons behind the low use, there could be numerous reasons. There have been very different barriers to the uptake of these medications that have been described in different resource settings, particularly in middle-income countries and low-income countries. And these barriers can occur at the patient level, at the provider level, or at the health system level. So it is quite a complex problem, because it requires, trying to address different challenges at different points in the care care in the care sort of cycle, right? And we really have to figure out in different health resource settings and in different areas, what the main challenges are in order to address them. But they do occur at many levels. So, availability and affordability has been identified as a key, barrier. But there's also, I think, another important barrier, which is manpower. I mean, this is the, cardiovascular disease is still, the leading risk of death globally, and the numbers of cardiovascular disease cases are continuing to rise globally. In that context, how do we have sufficient health, personnel resources to identify patients and treat them? So I think that's actually a very key part of the barrier that is occurring, where there just may not be sufficient, individuals that are able to identify, screen, and treat patients with cardiovascular disease, particularly because the number of cases are increasing so much.
Yes. And of course, we know that even if you're thinking about, say, the numbers of cardiologists, never mind, even just the overall numbers of doctors, the number of, low-income countries or low-middle-income countries is, vastly insufficient, to deal with the numbers of cases of cardiovascular disease that we're seeing, and what is clearly a growing epidemic of cardiovascular disease. Phil, as you had mentioned before, there have been, again, all of these global targets, that are looking at or trying to close these gaps in secondary prevention. In fact, in September of 2025, there's the second, United Nations high-level meeting on non-communicable diseases that's going to review the WHO's global action plan that, again, specifically calls out improving drug treatment for people who had high risk of cardiovascular disease, i.e. secondary prevention in people who've had prior cardiovascular disease. If, you were sitting in, at this meeting, and you possibly could be with the WHO, with the UN, what are some, what is some advice that you can offer? Like, what are practical and specific and maybe some concrete approaches? And I know you started to talk up through some of these approaches that we can really try to focus on as we think about the next decade in terms of really trying to close these gaps, so that, Phil, you and I are not having another conversation in 10 years or 12 years, talking about how the numbers haven't changed and how there's still a significant number of people who are not being treated for secondary prevention. So if we pivot now and really start to talk about solutions, what are, a few concrete solutions or innovations or ideas that we can bring to this problem that can help to address these gaps in a more concrete way?
Yeah, that's a very good question, Ari. And I think a lot of it requires coordination of policies and coordination of care that may not be existing in a broad sense that it could be. I still think, the way a lot of care is practiced in sort of, for example, in terms of cardiovascular disease treatment with, medications, is really focused in many countries still in terms of, the hands of a cardiologist or internist or primary care physician. And it's not thought of in terms of management in terms of a public health, problem. And, there are studies now that are showing that if we engage task sharing, for example, um, with non-physician healthcare workers and clear, mechanisms to reach reach physicians or, engage with non-physician healthcare workers, we could probably increase the adoption of these medications at the community level by quite a lot. And some data in terms of risk factors have shown there can be reductions in cardiovascular disease outcomes with that type of approach. And that becomes more and more important as the physician workforce becomes smaller in relation to the number of number of individuals with cardiovascular disease. So this exists in high income countries, but it's probably a bigger problem in middle and low income countries. So I think there needs to be engagement from communities and groups into understanding how to make these systems, like how to apply these systems in healthcare and how to share these tasks, how to engage these other groups because they exist. There are physician assistants, there are nurses, there are community health workers, there are many actual people that can be trained to deliver these type of therapies. And we just need the organization to try and create a system that actually can work to do that. And it's been shown in studies to work. So I think that's the other important point. The other point is using more simplified mechanisms of the use of these medications. So, for example, polypills, where patients can, receive will be taking multiple of these medications at the same time. So that increases their adoption and also their use. So that's another, example of how approaches can be adjusted to try and reach the maximum number of people with with the appropriate therapies.
Yeah. No, Phil, I think that, you're highlighting, really this public health approach to this problem, I think really is a key linchpin here. We absolutely cannot depend on sort of the individuals getting to cardiologists and creating bottlenecks. But, to me, there really has to be, some very bold, and really kind of bold targets around this. And again, not dissimilar to what has happened in terms of HIV treatment, for instance, and the very high targets for identifying people with prior cardiovascular disease, getting them on treatment with a simplified regimen, like a single dose poly pill, again, for which, as you mentioned, there's very good data for in terms of adherence and also in terms of improving some of the secondary risk factors. The use of non-physician health workers is absolutely an important way of being able to extend that care to reach the maximum numbers of people. And of course, if you're using a poly pill, non-physician health workers with a simplified treatment regimen, if prior cardiovascular disease, start on this medication, if this titrate up to 2 pills, I think then allows us to implement this more widely. But above all, again, something that I would like to see at this meeting is really kind of a renewed focus and renewed commitment to calling this out as really one of the key issues in cardiovascular disease management. I don't see how we're able to reduce numbers in terms of cardiovascular mortality and morbidity if we're not able to treat comprehensively this group of people that we know are really at the highest risk of recurrent events, and to increase the numbers of people who are on medication, on treatment, and on treatment for the long period, or over the long haul. But this is, I think, the reason why I was so excited. I'm so excited about this manuscript, because I think it provides important data in a place that is often, sort of a data-free zone, and really then allows everyone who is interested, everyone who is invested in this space to be able to make those important decisions, so that our next interview in 10 years will talk about how we have seen market improvements in the use of secondary prevention medications, across all countries, actually be them high, upper middle, lower middle, or lower income countries in the PURE study. So Phil, I want to, thank you again for taking the time to speak to us about the study. Actually, thank you for the very thorough analysis that you did for this manuscript, and obviously encourage anyone who's listening to be on the lookout for the publication, of this paper in JACC, and sort of other follow-up editorial comments and everything else that comes along with it.
Well, thanks so much, Mary. Yeah, thank you very much.
All right, thank you.